I'm Nancy Sutton. I'm one of the chair people of MedStar, Medical Referral. And this is a series I work with Rebecca Cohen, who puts all these things together, and then Sonia and I. And we're collaborating, of course, with the senior service. I'm going to let her say a few words. But we've been doing medical referrals for 25 years, and all along the way, we like to bring pertinent subjects. And I think that this is a really wonderful that we have wonderful people with us. We're very lucky. And I think Parkinson's very often touches a lot more people than you think. And so I think it could be very helpful, and I'm glad that everybody came out. So without further ado, you just...
Hi, thank you all so much for coming. My name is Victoria Sutton. I'm the director of the SBH's Senior Division. I would like to thank Bella Suleiman, who's going to kill me for giving her a public shout out, but she approached us a few months ago and said, this is something I think the community needs and I think we should offer. And if looking around this event and this great turnout is really because she came to us and wanted this done. So thank you for partnering with us. We are also honored to have Dr. Susan Bressman here, who's going to speak about Parkinson's management and an update on genetics. Again, if anybody has any interest in a caregivers group for this population or any other events, please speak to myself or MedStar after this event. Dr. Bressman?
Hold on. She wants an answer. I just want to say one quick thing. First of all, thank you to the Sephardic Community Center. We're collaborating, and hopefully we'll continue to collaborate. Nice when two wonderful organizations get together for the same purpose. And also, we're giving you little cards. If you have a question, please write your question on a paper and hand it to us, and the doctor will go through them.
Hi, I'm Sonia Didia, and really Dr. Bressman doesn't really need an introduction, but I feel it's only proper. She's professor of neurology at the Icahn School of Medicine, chair of neurology at Mount Sinai. She's well-renowned for her work on the research and the genetics of Parkinson's for over 30 years, and continues to expand the genetic factors of the disease. And we're hopefully she's going to come to a cure or getting there. Anyway, we're very happy to have her, Dr. Bressman. By the way, all questions, we're going to hand out cards to make the efficiency of the lecture go as smooth as possible. Could you wait till the end for questions and write them down on a card, and she'll be glad to get to all of them. Okay.
So it's a pleasure to be here, and thank you for inviting me. The last time I spoke to a specific audience on the Jewish story in Parkinson's was a Yeshiva University event in Jerusalem about 10 years ago, maybe more, right after the discovery of one of these genes. And it was a very interesting discussion because we knew very little. It was one of the first genes that had been identified. And it wasn't clear that finding the gene was going to impact anybody's health. We knew very little. There were no treatments directed.
I think they can't hear you in the back. So maybe if you want to stand behind me, just put that down. You won't have to hold it. It'll cost less.
And there was perfect. And then there was very little known. So part of the discussion was why learn about these genes and what they mean to me if it's not going to impact my life. And then I'll worry, and my kids will worry, and what's the use? Okay. So, and it's interesting now to give this talk so many years later, because we know so much more, and these genes really now have clinical impact, particularly in Ashkenazi Jews, which is why I'm talking to this audience, because I want to bring the kind of knowledge we have in Ashkenazi Jews to the Sephardic community, which I feel has sort of been neglected in this story, and hasn't been as studied as intensively as we've studied Ashkenazi Jews. That's sort of historic. So that's part of why I'm here, because I want to tell you a little bit about, what's happened in the field. We can talk a little bit about, I know people will have questions about current treatments and management and what we do. But it will be a plea to find answers specific to Sephardic Jews, because I think there are answers to be found, and the technology's way advanced right now. So we're really well positioned. We've started a little bit to advance the field and hopefully have targeted therapies and lots more insight actually based on studying the Sephardic community. So, how do I advance this one? This way? Oh, okay. So a little bit about Parkinson's disease. It's really based, we make the diagnosis, neurologists do, and internists as well. Lots of diagnoses occur with the primary care doctor based on motor changes in people's motor function. So there can be a tremor, that's sort of the most obvious hallmark feature, slowness, stiffness, and eventually people usually have some problems with balance. But the key diagnostic feature that must be present before we can say Parkinson's or even a Parkinsonism, because it's not one disease, is slowness. So it could be slowness, walking, getting dressed, buttoning, shaving, rolling over in bed, lots of things, or getting out of a chair or getting out of the car. So lots of things that you could do quickly, a person could do quickly, take more time, more effort, just occurs more slowly. And when patients come into the office, we have this dopey exam we've been doing for about 60 years, but it works. It works. We make people tap. We make them, swivel their arms around and tap their feet. And we look at the speed. And we see if people slow down or they arrest while they're doing things or they get small. But we look for the tremor. We test the tone to see if there's any stiffness. That's all important, very important. We've also learned that there are it's not just the motor stuff. There's a lot of what we call non-motor features to Parkinson's. And some of them can occur even before the motor stuff starts. So people will have problems with smelling. They'll lose their smell. Or there'll be depression or anxiety. That can happen. Problems sleeping, acting out your dreams. So constipation, which is very common anyway. So hard to know if you're constipated because you're developing Parkinson's. So it's not that useful, but it's useful when it occurs in a constellation. And the reason why identifying these non-motor features is important, A, is they affect your quality of life. They need to be addressed, and we need to figure out how to treat them. And number two, because some of them occur so early, they help us make a diagnosis even earlier than we're making now. So there may be ways with imaging and genetics and ranking and rating all these non-motor features that we can say, you know what, it's not fully developed, but it's almost there. And that allows us to start treatment, especially if it's a targeted treatment that's meant to cure a person or prevent worsening earlier, because that's our goal. Treat people maybe even before the symptoms start, which is the very beginning, and prevent the Parkinson's from fully evolving, or even maybe reversing it if we're really good at finding a good treatment. So the pathology, what's happening in the brain? The hallmark, most important part in terms of the motor manifestations are that these nerve cells, these neurons in the brain that make dopamine are affected early, pretty early, although not first actually. The constipation part and the smell part are actually the first parts of the nervous system that are affected. But pretty early it climbs up the brainstem into the dopamine neurons, and that's what causes the motor symptoms. And our treatment, we can talk about management, but medical treatment is really focused on augmenting, boosting, supplementing that dopamine system. So if you're missing it, we give levodopa, which is a precursor to dopamine, or we give dopamine agonists, which directly stimulate the dopamine receptor. And there are all different ways to give dopa that are evolving. We can talk about it in the question and answer. It's not just the same old pill. There are new types of pills. There are accordion pills that are being developed, patches, a pump. There's deep brain stimulation, which isn't dopa, but it sort of works on that circuit to normalize it. So a lot of what we focus on is sort of based on dopamine and that motor circuit that dopamine innervates. And that's really what the symptomatic treatment has been, which is great. And that along with physical exercise, which is very important and good for the brain in every which way, not just the Parkinson's way, and treating these non-motor. So if you're anxious, if you're not sleeping, if you're depressed, if you're constipated, paying attention to those and treating them. What we really want to do is cure Parkinson's. I mean, the ultimate goal is you shouldn't get it in the first place. And if you're diagnosed, what can we do so it doesn't get worse over time? And, neurologists used to be I mean, we were in the field of diagnosing people, but not really curing them or treating them really effectively. But now you can see in MS, in stroke, the kinds of advances we've made, and now gene therapies for some of these kidney disorders with muscle disease. So we've gone from, making a diagnosis and sort of being supportive to being much more proactive and changing people's lives in terms of what's happening with the pathology in the brain and what's happening in the brain. Okay, so what causes Parkinson's? The etiology. So it's gone back and forth. It's sort of like fashions and what people wear. I mean, is it the environment? Is it pesticides? Is it what you eat? Is it an infection? Is it genetics? It seems to run in families. And so there was this debate going back and forth. It's probably a combination of both, but it was very hard to pinpoint specific genes that were culprits until 1997, when this big Italian family, turns out it was a Greek-Italian family, was described with Parkinson's disease. And they had mutations, they had genetic changes in a gene that makes a protein called alpha-synuclein. And it was like, holy cow, what does this mean? What's alpha-synuclein? So it turns out that that change in the dopamine neuron, what the pathologists can see is something called a Lewy body. I think it's actually a Lewy body. I think the guy was Jewish, but and that's how you properly pronounce it. It's a Lewy body, and nobody really knew what was in the Lewy body. Well, it turns out alpha-synuclein is in the Lewy body. And so this completely revolutionized the field, even though alpha-synuclein mutations are not a common cause of Parkinson's. They're really just a handful of families that have these different mutations. Everybody started focusing on this alpha-synuclein. What is it? Why is it accumulating in these Lewy bodies? And it started a whole new approach, focusing on what does this protein do? Why is it collecting and globbing up and making these collections in the nerve cell? Is that toxic? Is it the actual body actually good, but there's a pre-toxic component? And so alpha-synuclein, too much alpha-synuclein, making too much of it, because one of the mutations that causes this is overproduction of alpha-synuclein. It became clear that too much alpha-synuclein is not good, and that when it's not handled properly and recycled properly, this protein clumps up, it collects, and it's actually toxic to the cell. And it's not only toxic to the cell, but it can get actually transmitted from one cell to the other. And they've made all these different animal models and figured out ways to try to either reduce the alpha-synuclein you make, or block its clumping up, or recycle it before it clumps up, or prevent it from being transferred from one cell to the other. So some of the biggest news, and if you go to the Michael J. Fox website and you're looking up alpha-synuclein, you'll see that there are all these drug companies now seriously, including vaccines, making vaccines, targeting alpha-synuclein to basically reverse the disease or prevent it from getting worse with early diagnosis. So that genetic finding has, it's not that long ago, it's 20 years ago, has really revolutionized how we think about Parkinson's. But we know it's not the whole story. So this is just a slide to show you what we do. So I've been at Beth Israel working with Debbie for too many years. I don't know, 22 years, and working for at least 10 years before that at Columbia, although not with Debbie, she's too young, on genetics in movement disorders, and really the last 20 years focusing a lot on Parkinson's disease. And what we noticed early on, based on a disease called dystonia, and then in Parkinson's, that studying Jews was a good thing to do. Ashkenazi Jews was our target, because there are a lot of Ashkenazi Jews in New York. The most common ancestry in New York City. And we knew that certain diseases were more common. We already knew, like Tay-Sachs, were more common in Ashkenazi Jews. So we figured, if we're going to find a gene in Ashkenazi, in Parkinson's, why don't we limit it to Ashkenazi Jews and see if we find something. So we would study our patients, collect information, get blood, get some other information, maybe some other different blood tests, but particularly for DNA. And then we would look for mutations and look for changes that were inherited together in families, particularly in families where you have big families. But even in singletons, if you're an Ashkenazi Jew, and presumably you all descend from about 300 families that survived in 1650, which is really what people think. So that was the kind of study we were doing. And then we would hopefully find genes, and we did this in dystonia, and we'll talk about this other gene, and then go back to the families and say, okay, now we found a gene, we need to figure out what that gene's doing. So we collect additional samples looking at, difference in protein production, or how different genes are expressed, or inflammatory markers, or imaging. Imaging is a big one. Is there something about the circuitry that's unique? So we would go back to families and get more information, basically to advance the science. So what's happened since '97, and we've been part of this, is that it's not only alpha-synuclein. We have all these other genes, by the way, and that's not a complete list. And the two big ones that I want you to look at, which are the purple and the yellow, are LRRK2 and GBA. And this is most other populations, and this is Ashkenazi Jews. There's some exceptions, like North African Berbers, where LRRK2 is very important. But in general, this holds. And what you can see in Ashkenazi Jews, LRRK2 and GBA are really important. About 30 to 35%, and if you have a family history, it's probably closer to 50% of Ashkenazi Jews have a mutation in one of these two genes, which is crazy. And the story I'll tell you, which is true, a little crazy story, is that LRRK2 was identified in 2004, end of 2004, by two groups. One was this sort of American-British group, and the other was more Spanish-focused. And they both had been studying these families and identified mutations in LRRK2 and said, oh, wow, we found a new gene for Parkinson's. This is very exciting. So then, this 2005, everybody's looking at all their stored samples of DNA to see, can we see mutations in LRRK2 and GBA? And people were finding maybe 1%, 2% of their population would have these different mutations. And we were working with a investigator in Lübeck, Germany, and she was screening her samples, and she had none. She said, not even 1%. That's pretty odd, but I'm not getting any. So she asked us to send her our samples. So we sent her our samples, and she goes, 20% of your patients have a LRRK2 mutation. It's a mistake. And it's like, we don't think so. So we sent her like another 80 samples. And yes, it was like 15 to 20% had mutations. It was the Jews. We had Jews and she didn't. So all of a sudden it became clear that this was a very important gene, but particularly in Ashkenazi Jews and some other groups too, actually Portuguese as converso Jews, Portuguese, Spanish, Italian. So LRRK2 turned out to be, and even in some Sephardic families, it turns out, which are not entirely Sephardic, or are, but in a complicated way. So maybe Spanish, maybe because it's the Spanish influence. So that was the LRRK2 story, and GBA is the gene that makes something called glucocerebrosidase. It's a very important enzyme, and when you have two copies of this, mutations in both copies from the mother and the father, you end up with Gaucher's disease. So it's a known gene that is common in Ashkenazi Jews that's been screened for many, many years, and there's enzyme replacement therapy. There are different kinds of treatments for it. And in adults, it can often cause, especially in Ashkenazi Jews, a relatively mild disease. And everybody thought that was the story. And if you were a carrier, you were fine. Two copies were bad, one copy was okay. Well, it turns out one copy increases your risk for Parkinson's. So it's another gene. Now, both of these genes are not determinative. In other words, if you have a mutation, it doesn't guarantee you're going to get Parkinson's at all. So for LRRK2, it's something like 25 to 30% of people with mutations in LRRK2 get Parkinson's, but 70% don't, and we don't know why. So that's one of the fields of research. What protects somebody from being affected? With GBA, there are different mutations. Some are called severe, some are called mild, depending on how they affect the enzyme activity and how severe the disease is when you get two copies. With GBA, it's even lower. With GBA, it's maybe 10%, depending on the enzyme. So not everybody who has the mutation gets the disease. So it's complicated. So what has happened? Let me see what's on the next slide. Is that my? Yeah, yeah. So this is just what I was showing before. So what's happened, going back to the families and looking at GBA and looking at LRRK2, is we can see that those two genetic forms of Parkinson's are not a little different. You know, Parkinson's is not one single thing. There's LRRK2 Parkinson's, which has its own peculiar features. There's GBA Parkinson's, which has its own peculiar sort of propensities in terms of getting into trouble with different things. So they're not exactly the same. So we can go back to patients and we can say, oh, is inflammation particularly important in LRRK2 or GBA? You know, the mutations affect how the cells work and their metabolism slightly differently. So, and we go back, we look at the imaging, we look at the markers. When people die, we try to get brains and look and see what's happening. And what we've seen, for instance, in LRRK2, kind of interesting. Not everybody gets those Lewy bodies. They're not always there, but they still have Parkinson's. How did that happen? Well, they're still doing nasty things to their dopamine neurons, but it's not as extensive. So maybe LRRK2 should have its own treatment. Same thing with GBA. It's a Gaucher's. It's how, you know, fatty sort of molecules are metabolized and recycled in something called this lysosome, which is sort of this like recycling factory. So maybe we should target GBA in its own unique way, because it's not quite like all the other Parkinson's, even though 30 years ago we lumped everybody together. So that's exactly what's happening. So now we have a study, a GBA study, Genzyme Sanofi. We've recruited, 4 to 6 patients already. We're working, Columbia's another site in New York that's recruiting. And who knows? But it's meant to arrest the progression of the disease by targeting what that enzyme is doing. It gets into the brain. And it basically prevents the accumulation of products in the brain that people think are toxic. We have another study coming in the fall. We're actually going to introduce normal GBA directly into the spinal fluid. And in monkeys, at least, it gets picked up, and it seems to sort of bypass the abnormality. So LRRK2, so what happens in LRRK2, we think that protein's overactive. And when it's overactive, it's actually toxic to the cell. And if we can cut down its activity, we can reverse that. So Denali, a very nice new company in San Francisco, has an inhibitor. It's not a cancer drug, but it's sort of like a cancer drug that's going to lower that activity of that protein. And it looks like doing that reverses the LRRK2 toxic effects in the brain. So we've gone from just giving levodopa to people, Sinemet, to now targeting the process in the brain based on a gene defect to reverse it. So it's light years ahead, but really it's only been 20 years in the making. So this is great. Okay, what do I have on the next one? Oh, so this just shows you what we did. We did a study, It's important to work in groups. Michael J. Fox is very good at doing this, the foundation. So we were studying our Jews, and Columbia was studying its, and Tel Aviv was studying its, and it was like, maybe we should work together. So you have, 100 patients, we have 100 patients with you. Let's join together, and then we have many more families. We could do much better analysis. So actually, Michael J. Fox did fund us back in 2009, and the grant really just ended recently, to do this study where we not only recruited families in the 3 places, but we followed them over time. So it was really exciting. Hundreds of LRRK2 patients with Parkinson's, without Parkinson's, from multiple families, to see the progression and what happens to people over time and how they respond to medication, and also to get all these specimens together. And now, of course, we're going to have an event coming up in the fall to try to get these patients to continue in different studies. And also, they're going to be in this LRRK2 Denali study. We're going to recruit for it and get these guys to hopefully do something very proactive to help slow the progression. So this has had, in a very short time, quite an immediate impact. And a lot of papers. That's just to show you we write a lot of papers. That's the academic. So we've learned a lot. As I said, we looked at we know the pathology. We still need to determine why some people get affected, never get affected. Some people become affected. We're following this elderly community dwelling people in the Bronx. This is part of the Einstein aging study. And so we can follow people with LRRK2 or GBA mutations who are in the 80s and 90s, 100. And they don't have Parkinson's. Okay, so they escaped. So we want to know why they didn't get it, whereas they might have, a nephew who's 30 who has it. So we're trying to figure that. And we're trying to figure out, for the drug companies, what they need to know is, LRRK2 it progresses pretty slowly. So their question to us is, how will we know if the drug's doing anything? How are we going to do a study? If it progresses so slowly, how are we going to know? So we have to look for these markers and show that they change over time in LRRK2. And the clinical exam might not be enough. There might be some blood markers we need to, or spinal fluid markers we need to look at as well, to make sure the drug's getting in, it's doing what it's supposed to do, and that we can see a difference between people taking the drug and people not taking the drug. So it's complicated. And for the FDA, it's very complicated because they want to show unequivocally. Anyway, this just shows you, it sort of shows you what I've been discussing in terms of reducing LRRK2 activity, okay? Because that's, GCase is the glucose cerebrosidase, that's that GBA. We got to get that activity up. Alpha-synuclein, we got too much of it, so we got to bring it down. So this is basically a slide from a recent paper showing how the treatments have evolved and how we're really getting to underlying pathology. In the past, it would be, we'll give vitamin E. We'll give vitamin C. Or maybe we'll give coenzyme Q. But these were like whole brain, maybe slightly positive things to do, but not this targeting, getting into precisely. Okay, so, we occasionally do have patients of Sephardic origin who have LRRK2 or GBA mutations, but not commonly. And we have a bunch of particularly Syrian Jewish families, but we can look in other communities. We haven't looked we have a lot of Syrian Jewish Sephardic families, so that's what we know best. And we've looked for genes in LRRK2, we've looked for mutations in GBA and LRRK2, and for the most part, we don't find it. And so we think it's different. And we're not surprised, because it's true for other Ashkenazi diseases too, that the frequency of mutations is not the same. And it has to do, there are different theories about where Ashkenazim came from, and the bottom line is the population was decimated in the 1600s and then blew up. So whatever genes and mutations were present in that small founder group, which has Middle Eastern pieces to it, are very common now. whether it's Tay-Sachs or our dystonia gene, but that the Sephardic population is different. Okay, it shares some its commonality with the Ashkenazim. So this was the there's not a lot out there. This was the one paper Debbie and I were looking for it. But it shows you Jews. If you're Jewish, you're in brown. It doesn't matter where you come from. So you can see the Jews sort of share this kind of Middle Eastern, European commonality. But then when you go back and you look at Jews and you look at their ancestry, all of a sudden it comes apart and you can see differences. And you can see Iraqi Jews. So when it's in orange, that's actually Jewish. So Iraqi, Italian, there's Syrian between Iraqi and Italian, there's Ashkenazi, there's Greek and Turkish, and that's sort of another analysis looking at the same group. And here are Syrian Jews. So, not surprisingly, it's a little different. And some of the same founder mutations that we see, from that bottleneck that happened when Jews were decimated in Eastern Europe, aren't that common in Sephardic populations. It's sort of different. It's a different kind of gene pool. And it hasn't been investigated the way the Ashkenazim have. So we just went at it by having families. Debbie Raymond, she's going to answer questions as you're going to come up here. We've been having families come to us for years with Parkinson's. Sometimes the only person in the family, sometimes there are two, sometimes there are three. Some of the families have typical Parkinson's. Some of them are a little more atypical with more cognitive problems. So as I said, it's an array of different types of Parkinson's. And then we're getting smarter and we can screen for all these different genes. But even screening for all the genes and the genes that cause cognitive problems, we still have families with nothing. And we go, that's impossible. There has to be a gene here. We just don't know what it is. So that is what we want to do. We've been doing it for years. We want to collect samples in all our families. We always invite people to give us samples when they come to the office for research. And some of you were in the audience here and know I've tortured you to try to figure this out. So first of all, finding a gene is gigantic, not only for the Sephardic community, but for the world, because it gives us a new window into Parkinson's. So it's gigantically important. And it'll be important to bring the kinds of treatments that are being developed for other genes to this community. So that's part of my pitch. I've been wanting to do this for, 20 years when we first screened our Sephardic families and said, nothing. Not even an interesting, something. So we know we have to go and look really carefully. And we may have to be creative because there's a lot of intermarriage, a lot of families marrying families. So we're going to have to do some more interesting statistical analysis. But I think it's doable and it's something we should do. So that was my pitch, my research pitch. So, and Debbie is our genetic, so we have a team here. So Debbie Raymond is our genetic counselor. So and then we have Sonia, Sarah, and Ellie in the back. That's, as you see, waving there. We have the best research team, I have to say. And what Debbie does, which is really important, is not everybody wants to have genetic testing. And so that you sit with Debbie and you go through the pros and cons. Like I've had patients say to me, I don't want to be in a trial yet. Till I know it works out, I'm not interested. So I don't want to know. Because if I know, then I have to tell my kids, and I don't want to tell my kids. And I don't want to keep a secret from my kids. So, you talk it out with Debbie before you go for testing. However, for research, you can go for research. You don't have to know your results. If you go for research, so for counseling and testing, there are two kinds of ways you can do genetic testing. One is you want to know the results. You go, I want to know. But before you actually go for the testing, you talk to Debbie, because people sometimes don't really want to know. You know, they think they want to know, but then when they think about it some more, unless they're really going to be in the trial, they don't want to know. And if you don't have Parkinson's, but you have a family member with Parkinson's, and the trial's not for you yet, you may really not want to know. Why would I want to live with that? Worry. So that's why you talk to Debbie first. But for research, you don't have to know your results. You can if you do. We can arrange for that. But if you don't, that's fine. We'll take your DNA and we'll try to use it to find these genes. Debbie was going to tell you a lot more. Okay. Yes, my mom has Parkinson's. She's 89 with a family history. Is it important to test her? So I would say to test her, you know, it depends if she wants to know. It's the same thing that I just said. But for research, I would say absolutely. Because what ends up happening, and we always say this, you know, we like to get all the generations. So, you know, anybody in the family with Parkinson's and any of the intervening relatives, we're always interested. Because we're thinking there's some genetic change, especially in a family. They probably, not always, we're fooled pretty often, but not all. But the general hypothesis and what stands true is if you're first cousins or an aunt and uncle and a child, they probably share, and their Parkinson's looks the same, they probably share the same change. Although Debbie can tell you how many times that hasn't proved to be the case. But that's how we generally go, and the likelihood is more that. So we always like that. So getting that. So if she wants to know the results, fine. And if she doesn't, for research, I would say. What is the relationship between Parkinson's dementia? So that's a whole story. So dementia, like the leading causes of dementia, you know, there's Alzheimer's disease is a leading cause. And that has its own pathology and changes in the brain and its own, you know, research community. And then you have and they have something else. They have these plaques and tangles. It has its own pathology. Then you have Parkinson's disease, which has these Lewy bodies, and it's sitting in that corner over there. But there's another kind of very common dementia called Lewy body dementia. And it sort of sits, and there's a lot of publicity about it lately too. And it's pretty common. So it looks like Parkinson's in the sense that it has the Lewy bodies, but it's not just in the brain stem, it's really everywhere, and it spreads pretty quickly, and it can cause dementia. And then sometimes, just to make everybody crazy, you can have Alzheimer's changes and Lewy body changes together. So, and we know in Parkinson's, over time, a not insignificant number of people, probably half or more, develop cognitive changes. It may not be dementia, but some problems with executive planning, maybe a little bit of word finding problems. So, and it's sometimes hard to separate that out from normal aging, but cognitive issues can occur even in regular Parkinson's and can be an issue. So there's a relationship. Then there are a whole bunch of, somebody asked me about this, of frontotemporal dementias. So there's a slightly different pathology, overlaps a little bit with what you see in Alzheimer's, but it's different, that causes, can cause dementia and behavioral changes too. So language problems, behavioral changes. And it's in its own category. There are known mutations that can cause that kind of dementia. Some of those people who have it also have some motor issues and a little bit of Parkinsonism. So that's when I send somebody for testing to Debbie and they want to know results and they have cognitive issues, what we'll often do is do a big panel. So we'll do the Parkinson's genes, but we'll also do the dementia genes, and we'll include these frontotemporal genes in there. And sometimes we find something. We actually did have a Turkish family, right, that had some interesting changes. So we look. So sometimes, one of the issues is, are we just missing some of known genes in this community versus finding new ones? It's both. Or known genes, but no one really looked for all the mutation types. So that's the other thing we can do. Okay, let me see what else. So is genetic testing for Sephardic Jews available? So that's, yes, although the odds of getting a positive hit are lower, okay? Roy Alcala is one of the geneticists up at Columbia, and he has a couple of Syrian families with LRRK2 mutations. So, it can happen. It's not like in the Ashkenazim, but it's possible. So, you can absolutely do it. And especially if it's an atypical Parkinson's, we may find one of these other genes. So I would say, but the odds of getting a positive result are lower. Okay. Yes, family member. Okay, so that's the other question. So what if you don't have Parkinson's, but you have a family member with Parkinson's? So actually, as part of the Michael J. Fox study, this was restricted to Ashkenazi Jews, if you were Ashkenazi Jewish and you had like a parent with Parkinson's, but you didn't, you could be in their study. They would test your blood and recruit you into the study. And I can't tell you how many kids send their blood in for 23andMe. They get back the results. They find out they're LRRK2 or GBA, and then they tell their parent. And like, Mom, you should do this too. And then the mom's stuck, maybe didn't even want to know. So it's kind of this funny thing that's happening with this direct-to-consumer testing, where people can just get their gene status. So and it's a different generation. They want to know. So it is interesting. So we tell people in terms of doing that, you definitely need to counsel, because if you have the diagnosis, you're already in the books as having the diagnosis. So if you want long-term insurance or your employer, it says Parkinson's disease. So whether it's Parkinson's due to LRRK2 or Parkinson's not due to LRRK2 doesn't make a huge difference. On the other hand, if you're healthy and somebody finds out you have a genetic predisposition, it might affect some, and Debbie can talk about that. It might affect some insurance issues and also make you crazy and worried. So I definitely, when people don't have Parkinson's but have family history, I always send them to Debbie to counsel and to think about it. That's why this 23andMe stuff, where you don't really get that kind of in-depth counseling and all of a sudden you get the results. My daughter did this. I could have killed her. And plus, you find out that you have relatives in Europe that you didn't know about. And you're going, I don't know if I like the family I have. Now I got to get that family. So, too much drama. Yeah. Are non-essential tremor a prelude to Parkinson's? So tremor is interesting, yes. So sometimes people, and we don't always know what to do with it, and the scans aren't always positive either, will have a little bit of tremor for years. Sometimes we really think it's essential tremor because, we can see it when people put their hands out, they have this squiggly handwriting, they have problems pouring, and we call it essential tremor. And there's been a debate in the literature forever, and it's still debated, on whether people with essential tremor are more likely to develop Parkinson's. Maybe. So that's one category of tremor, really essential tremor, and does it increase your risk for getting Parkinson's? Then there is this other group that has a little bit of tremor, benign tremor, comes and goes for years, and then they do develop full-blown Parkinson's. It's just kind of slowly, happening, which goes to my story that no two people with Parkinson's are alike. Some people will have 20 years of Parkinson's and practically nothing happens, and they're fine, and they do well with medicine. And other people, after 5 years, 1 million problems. And some of this we think might be these not just one gene, it might be gene-gene interactions or gene environment that makes makes the Parkinson's progress at a different rate. And that's one of the things we're trying to figure out. What are the accelerants, Okay, if one has the LRRK2 G2019S mutation, can one determine whether whether can one determine whether he has Lewy bodies when he is alive? Okay, so the assumption, that's actually a good question, because if you have LRRK2 mutation, the G2019S, the odds, and you have Parkinson's, the odds are you have this Lewy body pathology, but not 100%. So there are people with LRRK2 G2019S mutation with Parkinson's who die and don't have Lewy bodies. They do have some nigral degeneration, so the brain is not normal, and those dopamine cells aren't normal, but they don't have the full-blown picture. And some LRRK2 patients, and we know this is part of this paper we just had came out, do progress more slowly. So we don't know why. So, this is another interesting question. Would you prescribe nilotinib? With the mutation, with that. So, good question. So the nilotinib study is happening. They are doing it. It's a joint venture between, trying to think it's definitely Michael J. Fox is a major funder of this. I don't know if Northwestern actually has money in it, but it's coming out of Northwestern, and we're participating in it. And the first phase is ended. So the first phase basically took people with pretty advanced Parkinson's who've had it for years and actually had some balance issues. And they recruited nicely for it, and now they're analyzing it and looking at the doses. The next phase, should it happen, we will know after the summer, is to look at newly diagnosed people. So we'll find out. So I would say right now, I've had some patients that I've given nilotinib to because they had such terrible Parkinson's. I said, what the heck, let's try it. There is anecdotal reports, and there was in the original report of 12 patients, that it helps. That's why we're doing this study, and we don't know yet. So the bottom line is, there is some promising evidence, but the real study is underway. Okay, so this is the same question, I think, but I want Debbie to come up.
So, hi everybody. I work a lot with all the patients who are both interested in learning more about the genetics, whether they have a gene for Parkinson's disease, and also with the research. And as Dr. Bressman was saying, some people want to know, and some people don't want to know, and some people just want to participate in research without knowing, and other people would like to find out. For all the reasons that Dr. Bressman mentioned, if you have potentially one of these genes that we're working on that, where treatment might hopefully become available, it might be something that you want to find out, but we're not sure in this community whether there's, louder, I have a soft voice, sorry, whether there is, whether there may be probably a lower chance of having these specific genes, and we have a lot of work to do to really find some of the other genes that may be involved so that we can do a similar kind of thing that we've done to try to understand these genes better. And Dr. Bressman also mentioned that, why genetic counseling is important if you are thinking about having testing for these genes. And basically, it is, everybody feels differently about it. When we talk to patients, we want to make sure that you understand what we know about Parkinson's genes, what the chances are of having a positive result, and what would it mean to, if the result is negative, does that mean you don't have a gene? Well, no, it doesn't. It just means we haven't tested for those genes. We may not know them yet. You can even have an unclear result, and what does that mean? So a lot of it is preparing you for the possible types of results you can get. What would that mean for you? Does that have an influence on your medical treatment now? Could it have an influence later? What does it mean for your family? and all those kinds of issues in terms of, are you somebody with Parkinson's? Are you somebody without Parkinson's? Could that have, any kind of implications for the things that Dr. Bressman mentioned, such as insurance or, concerns that people have about privacy and that kind of thing. So those are all types of things that we want you to think about ahead of time and make sure you're comfortable with when you have testing, and that you also have realistic expectations about what we might or might not find.
Can I give you these questions?
Oh, sure. That's a lot. That's a pack of questions. Okay. Okay. So this question is, what if you've been tested for a Parkinson's gene and you're positive, and what can you do before symptoms start? And of course, that is where hopefully we're going with some of these, what's coming in the future. We don't have anything really right now, but we always tell people that whatever you can do to lead a healthy lifestyle and take care of yourself and so on, exercise, all those things for, just to be healthy in general, it might help, for this disease as well as other diseases. So that's definitely something you could be proactive about. But in terms of really preventing the onset of symptoms, we don't really have anything yet, but we will.
Yeah. I think if this LRRK2 kinase inhibitor turns out to be really safe, this would be an example of some really super safe version of it that doesn't have any long-term toxicity. It would be something potentially that carriers, gene carriers, even without Parkinson's, would take. Sort of like I think of it this way. You haven't had a stroke or a heart attack, but your cholesterol's high. You're going to take your Lipitor. Your blood pressure's elevated. You're going to take you haven't had the heart attack or stroke yet, but you're going to control the blood pressure. So it's sort of the same thing. If this LRRK2 activity predisposes to Parkinson's, and there's some Lipitor out there that'll help prevent that from being a problem, you're going to do it. It's sort of risk reduction as opposed to a cure. Just think of it as lowering that risk.
Any information connecting colitis and PD?
Oh, God.
That's sort of a can of worms.
That is a can of worms. So we're doing research on it. Okay, we're doing research on it. And
There is LRRK2, for instance, one of these Parkinson's genes, does also have changes in it that predispose to inflammatory bowel disease. So, and it's very interesting to us, this relationship between this particular gene, its product, and why it's important in ulcerative colitis, Crohn's disease, and also Parkinson's. And of course, every time we have a patient who comes to the office who has Parkinson's and ulcerative colitis, they're doomed because we're going to draw tons and tons of blood on them. And it may have to do with some inflammatory process and what LRRK2, how it interacts, in the bowel and in the brain. Because the other interesting thing is the relationship between what's growing in your bowel and what happens in your brain. I showed it at the very beginning that the pathology, if you look at the first, not in everybody, but if you look at the first evidence of pathology in Parkinson's, you can see changes in the olfactory bulb and in the ganglia, in the nervous system that innervates, the parasympathetic nervous system that innervates the gut. So when this was reported, people thought, crazy. This is crazy. And then it was, well, you know what, maybe Parkinson's is infectious, and you breathe it in, or it's something in your bowel, it's some gut thing, and that gets transmitted up to the brain. Which seemed lunatic, but it's no longer lunatic. It's a bona fide, accepted hypothesis that there's something going on, because now they've done animal models where, depending on if they clean the gut out of all the bugs in it versus not, it changes whether the rodent gets Parkinson's. So there's something going on. There is something happening, but it's still it's being investigated. It's actively investigated. And the Michael J. Fox Foundation paid money, lots of money, to different groups to look at biopsies of the bowel, parotid, the submandibular gland. These glands can sometimes show changes of Parkinson's. I mean, they tried to get olfactory bulb. That I don't know how easy that was, but to try to make a diagnosis in life before there's actually disease in the brain, to see if they could do that. So that's sort of an ongoing. That's a work in progress to find out if we can't make an early diagnosis with actual pathology behind it. And there are all kinds of reasons. So some of the tests are positive, some of the studies are negative, so it's controversial.
So I think these are probably mostly for you, I'm guessing.
Is there a national medication to alleviate Parkinson's? So yeah, I mean we do, as part of like,
No, this is just different questions.
oh, okay, I see, is there, so natural medications. So Parkinson's disease, I mean, we have a whole bunch of things, when people are diagnosed, that people do to help their Parkinson's. So, no one knows the perfect diet. Everybody says, what should I eat? I wish I knew. I wish I knew for myself. But no one knows. We say healthy. So, stay away from the processed foods, from the very sugary foods, healthful foods. Should you have more or less fat? Is the ketogenic, is a sort of a modified ketogenic good for the brain in Parkinson's? Maybe a little bit of data, but then we know that the Mediterranean style diet with lots of fruits and veggies is good for you. Constipation's a problem, so you should eat stuff that doesn't make you constipated. So, we sort of drink a lot of water. Nobody wants to drink water because then they're running to the bathroom all day. So we say the bathroom's your friend. Whenever you pass one, you go to it. And keep drinking water, because, the other problem people with Parkinson's can get into is blood pressure problems. So when they stand up, the blood pressure drops. And then if you're on a blood pressure medicine and you have Parkinson's, you can faint when you stand up. So we tell everybody to drink a lot of water. So water, diet, exercise, lots of exercise. The best exercise, again, we say aerobic is good, do so many hours of getting that heart rate up. But for some people, that's hard to do, and their real issue is mostly balance or posture. So then it's core and Pilates. So depending on what your problem is, it's like a slightly different regimen, but exercise is absolutely good. Multivitamins. B12 deficiency is bad for Parkinson's. We check it in probably all our patients. We check, you don't want to be D deficient, you don't want to have any of your B's deficient, you definitely don't want B12. So it's hard to get toxic on B12. So we tell people, supplementing your B, especially if you're in the low range, definitely do that for B12. So the vitamins, it's a mixed story. I have patients come to me with this many supplements, and it's hard to know. I mean, mostly I just want to make sure they won't be harmful. There's not too much or too high a dose of anything. Then there is this mucuna. I have a lot of patients who take that. It's an Indian, I think, herb or plant product that is like levodopa. It actually it has levodopa in it. So it has the precursor. The problem is I don't know how much per tablespoon or pill. So some people like it, and I don't. I'm sort of hands off on that. Yeah.
What did you just say the name was?
Micuna. M-I-C-U-N-A. I'm probably saying the wrong thing because I'm starting something you didn't know, but I don't. But a lot of patients, it's sort of in the literature there of patients using it, and I'm not. I don't give it and I don't promote it because I don't exactly know what patients are getting. But there is some research going on into it to trying to figure out what is in each of these pills, and if a low dose of a regulated mucuna could actually be good. It's a possibility, yeah. Somebody wanted me to elaborate on something.
Yeah, what happened in the 1600s?
Oh, what happened in the 1600s? So, okay, so that was, what's his name? It was I'm blacking on his name, 1650. Oh, yeah, hold it. oh my God, it was 1650, and it was the, no, it wasn't Cossack. And I'll remember his name when I'm sitting in the back. But it was, decimation of the Ashkenazi population in Eastern Europe down to, okay, so people argue. It's a very interesting argument, like with 1,600 people living, 2,000 people living. But it turns out there were only a handful of highly reproducing families, the more well-to-do families. This is a hypothesis. It's debated. So in fact, the Ashkenazi Jewish population in that period was really pretty tiny. The gene pool was. And they call it a bottleneck because here you have, Jews in Eastern Europe all over. And then, I'll remember the name in a second, you have this decimation. You have a small population surviving and even a smaller group of better-to-do families that had large number of kids. So in fact, it's a relatively small gene pool. And then in the 1700s, it was good for Jews. And all of a sudden, the population explodes. Lots of big families. And so whatever was in that little gene pool is now in everybody. So that's the Ashkenaz, that's the story. So that's the 17 and 1800 story of why certain diseases are more common in Ashkenazi Jews, because whatever was in that bottleneck is what's in the group now. And some of those families did have Middle Eastern ancestry. So it is a mixed group. Actually, when I read this paper, Jews share more in common than are different. And it goes back thousands of years. But in fact, when you think about why certain mutations we find in Ashkenazim much more than in Sephardic communities, there are these differences too. And that gene pool, that little gene pool, has peculiar mutations that are much less common in the broader Mizrahi and Sephardic populations.
Michael J. Fox, what was his?
What is his problem? So he wrote a book actually about it, and it's really that he started very young. He was 29, and he started with a tremor, and he was in the business, in the entertainment business. So it was really hard for him for years because he was hiding his tremor. And he had surgery, he had an old-fashioned thalamotomy, and went on medications very early in his career because he was performing.
He always looked different.
Yeah. Another question.
Is there any physical therapist that you would recommend?
So I don't have the list with me. Oh, any physical therapist to recommend. So, we do have a list. It's really probably not kosher to do this because we don't vet the end. It comes from patients. So patients will say, oh, I saw this physical therapist who's fabulous and whatever on King's Highway or whatever. And we'll write it down if we trust our patients basically. I think it's as good as Yelp or, they tell us. So, but we don't go out and actually survey. So it doesn't really have our stamp of approval. It's basically patient recommended list. And there definitely are different physical therapists in Brooklyn that our patients have liked, for sure. And there's something, so that Lee Silverman, many, many years ago, Lee Silverman created a voice therapy to get you loud. And now they sort of expanded it into the body. So they do Lee Silverman Big. So as part of Parkinson's therapy, it's physical therapy, but it's also speech therapy, like this Lee Silverman Loud. And the Lee Silverman Big, which gets you from being like shrunken to open. And patients like it. And boxing. Rock steady boxing is the other thing that people love, especially the guys. The women sort of like the dancing a little better. But women have women boxers too, because it's very good. Because it's not just boxing. They do a little core. It's aerobic. It's got balance work. It's got reaction time. So people like it.
Kinesiology.
Oh, yes. Well, yes. So different patients kinesiology. It's basically working through a physical therapist and also an occupational therapist. We didn't talk about that. on ways to move your body efficiently and effectively, and to prevent falling or hurting yourself at home too. So what's the best way to get out of a toilet? What's the best way to get out of a couch? So sometimes having like Fox Rehab, we send into the house, and they will send specifically trained Parkinson's therapists to help you with everything, whether it's turning in the kitchen, opening the refrigerator door so you don't fall back, a whole bunch of different things that they can help you with in the house, which can be very, very helpful.
What's the reasoning that Parkinson's is more common in men than women?
That's a great question. Why is Parkinson's more common in men? There's a joke to that, but I won't go there. So it is more common. However, I have to tell you, with LRRK2, it's not. In that genetic form, men and women are equally affected. The answer is we don't know. I mean, we think potentially women are maybe protected, maybe to some degree by hormones, maybe, or that men have some exposure that women don't have. Maybe they shouldn't play so much golf. I'm only kidding. But there's a whole pesticide.
Right, pesticide aspect of it all is...
Yes, so maybe there's some occupational or other risks that men are more exposed to than women, or some protective piece to women. I mean, yeah, so we don't know. I mean, men and women are so different, and the more we learn about our brains and our biology, it's almost amazing that we get the same diseases. But anyway, it's interesting. But with the genetic form, especially the highly penetrant genetic forms, the gene takes over and the gender's less important. Yeah.
I'd like to ask you, what caused the stiffness and if it can be
Avoided. So the stiffness is due to the dopamine. What causes the stiffness? So the stiffness, actually, like the slowness, is due to the dopamine deficiency. There's something about that dopamine input into that circuit. It's like driving with the brakes on. That's what we tell medical students. It's like you're trying to move, but the brakes are down. So everything gets slowed down because that dopamine facilitates the ease of doing it. So we think that that's it. It's that circuit slowing down the way your motor system can send messages.
How it can be avoided?
So, I mean, the things that help, the dopamine replacements therapies. Now, I didn't talk about it. That is going into a high gear too. So, it used to be you had Cinemet long-acting, you had the blue pills, the yellow pills, and then if they didn't work, you would go for deep brain stimulation. But now we have, which still works and is still a reasonable alternative for people that respond to Cinemet but don't do well over time. But now we have long-acting. We're going to have a patch. We have a caged pill. I mean, they're developing better ways, and there's of course a pump that you can put into your stomach. They're developing ways to get a dose of levodopa into your bloodstream continuously that agrees with you.
Okay, now, thank you so much, Dr. Bressman. I want to call your attention to a few people in the room if you have questions. Dr. Bressman graciously agreed to stay a few minutes with her team who can answer any family-specific questions you might have. I'd also like to call your attention to Linda Ebert from the Sephardic Center who came today, and Louis Ezrick, a community physical therapist. As Dr. Bressman mentioned, it's very important to stay physically active, so please speak to them about what the center can offer in terms of physical activity, as well as Mr. Ezrick about his practice. Thank you all so much. Thank you.